Andrea Foltz here.
Morning, Andy. Thank you. Hi, Greg. All right, let's go ahead and get started. Good morning, all. My name is Dawn Mautner. She, her, and a are my pronouns. I welcome you to this morning's Public Employees Benefit Board meeting. Call this meeting to order. Let's go ahead and take roll. Siobhan Martin, are you here?
I am here. Good morning.
Good morning. Greg Klauser. Hi, Greg. Chicky Flowers.
Good morning, present by video.
Thank you. Good morning, Chicky. Andrea Foltz, I see you. Good morning. Kimberly Hendricks.
I'm here. Good morning.
Good morning, Kimberly. Sean Parkman.
I'm here, just getting everything plugged in.
Thank you, Sean. Good morning.
Morning.
Emily Wong, are you with us?
Yes, I'm here.
Good morning, Emily.
Good morning.
And Rep Rob Nose, are you with us this morning? I don't hear Rep Nose, but we'll keep an eye out. All right. So if I may, welcome everyone to the PEBB meeting this morning. We have a pretty full agenda. I will welcome everyone to help us stay on track with our agenda this morning, including some public comment for the end of our meeting. Board members, have you had a chance to review the minutes?
I have reviewed the minutes and I will make a motion to approve them as written.
And I would second that. Kimberly Hendricks.
Thank you, Siobhan. Thank you, Kimberly. All in favor, say aye.
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 Any
Aye.
opposed?
Aye.
Thank you. Any opposed? Hearing none, the meeting minutes are approved as written. And I will go ahead and hand it over to Emery Chen with Mercer to talk with us a little bit about the Risk Stabilization Fund. Emery, are you with us?
I am. Thanks, Chair.
Thank you.
All right. Hi, Board. Today, we're going to go through the Risk Stabilization Fund analysis. So what we're going to do is we're going to take a look at essentially where costs came in and the stabilization fund is for 24, and then project out costs for 25, 26, 27, and 28, as well as the stabilization fund. So it basically gives you a future look at how claims and costs have been coming in and how that we expect them to go compared to the money that PEBB currently has to help account for any fluctuations or essentially get to that 3.4% funding that comes in. So actually moving on to the next slide. Just a quick note on how we determine the target. We use the risk-based capital calculation. It's a version of it from the NAIC. Based on prior analysis, we determined what would be sufficient, what level of RBC would be sufficient to account for any fluctuations for PEBB to make sure that the self-insured accounts are well funded or funded well enough to pay for all of the claims that are coming in from or going out due to the benefits. So the one thing that we focus on is really the risk to PEBB, where the claims are going to be coming in higher than what the funding is or what's in the stabilization fund. So if we move on to the next slide. the left side basically talks about how we do on underwriting, how we determine the rates for the future years. But the one on the right, I kind of want to focus on a little bit right now, especially if you've taken a look a sneak peek ahead at the RBC analysis. There are certain things that are happening with PEB right now, which I think does unfortunately put a little bit more risk than there has been uh, in the most recent few years. While we anticipated like a pandemic would essentially result in really high costs, it actually ended up creating surpluses for PEB. But that said, claims do come back. We are reaching kind of essentially the new normal. And with that, we are seeing higher trend, higher claims, and that's something that we're going to talk about in the upcoming slides. The population of PEB also has been changing a little bit. It has definitely been growing. And with that, there's certain advantages and certain disadvantages as well. These members are new groups coming on, and there is, while we take a look at their claims, there's a little bit of uncertainty about it. But the third line, I think, also is a big thing that's, especially with the longer session that's happening right now, it's legislation. As we've been looking through the legislation, those are not accounted for, at least the proposed legislation in our analysis. I believe, based on the work that's being done by the plans to determine the impacts of the legislation, it seems like every bill is going to kind of potentially that impacts PEB might be adding money, adding costs. And so those are not accounted for and does need to be taken into account that, even if you do meet the 3.4% with, whatever changes or, the claims, there's potentially legislation out there that could be costly and end up either taking away ways to save money for PEB or, adding costs in the future. And so that's going to be impacting PEB and would then therefore potentially put PEB at more of a risk to meet the 3.4%. And then on the final item, I think this is something that's actually happened for one of the plans. There's been some large claims. And so those, those sometimes are kind of random, but these large claims do impact PEB. And for 24, there were some large claims that we're not projecting to happen in 25, but did impact the 24 plan year. Okay. Oh, Ali.
Yeah, thanks, Emery. Just a quick note on legislation. So kind of part of our process when we are asked for bill analysis, we always do put language in our fiscal impact, if there is one, that this legislation would impact premiums, and offer a range. And we have kind of a disclaimer statement that we put in that, with the statutory cap of 3.4%, any mandated changes to benefits that would add costs would put the board in jeopardy of not meeting that test. So that is something that we put in all of our legislative analysis. Thanks.
Thank you, Ali. Okay, if there's no more further questions or comments, we can move on to the next slide. So this is kind of a summary of the results. So unfortunately, the costs have gone up. The last time we did it was back in, I believe, July. So essentially, we would have had like essentially 6 months of 6 months prior in terms of the claims. The cost did go up in the second half of the year. Before, as you can see on that first line, there was a surplus projected about $35 million for 2024. Now it's basically a $300,000 deficit, which is, essentially what we had projected, but the surplus that was coming in is now gone. And so costs have gone up 3.35 million, which is, to about 3% compared to where we were kind of expecting it last time. So unfortunately, that does have a knock-on effect for future out years. So 25 is now projected to end in a $20 million deficit. Before we were at $15 million surplus. Just a little note on 24 and 25 in terms of the transfers out there. And so with those, projected deficits, you're still above the target for 25. 26 is now going to projected to be below the target, and then 27 and 28 are, without any changes, is unfortunately looking worse. And it is increasing because we're talking about, 50-60 million dollar deficits, where without any plan changes, you do end up in a negative potential fund balance if no changes are made in 2028. And then this bottom line here, so this is a preview of the round one renewal results. There will need to be about $68 million in savings in order to achieve the 3.4% in 2026. So unfortunately, on this Tuesday, I do not have good news for you. Andy.
So just to clarify, if there was not a $90 million transfer out, we would be okay.
You would be okay, although you would still be spending down the surplus without any changes. But you would be above for 26, and I would have to check 27 without any changes. I think you'd probably be below. I don't quote. Well, I guess you are quoting on this bit. We can take a quick look, but 26
That's
would
all
be
right.
okay.
Perfect. Thank you.
Okay. Any other questions or comments before we move on? Okay. Next slide, please. So this one, this is what we typically show for the first slide. It shows essentially what we say as the market trend rate. So it's what Mercer has seen in Oregon and nationally as well in terms of the healthcare trends. These are a little bit different from what the plans have provided in their initial renewals. Unfortunately, the plans actually, based on their initial renewals, do have some higher trends than what we're using here. So for medical, we have 6.5%, pharmacies at 10, and then dental visions 4 and 3 respectively. So the chart there on the left, so the purple line, the one without the bars, essentially is the ending fund balance. So the stabilization fund balance. You can see for 24 on the left and 25, you are above the you're above the pink line that's moving up, which is the reserve target. And so, but once we get to 26, you start dropping down. And to your question, Andy, yes, you would be above the reserve target by about like $10-15 million. But then 27, the delta between the target and ending fund balance is growing as essentially the costs are projected to increase, but more than the 3.4% funding without any plan changes. So, so that is a downward slope with the 28 ending fund balance actually negative in this case. So, unfortunately, yes, costs are increasing more than funding. There potentially has to be changes to meet that 3.4%. We will update as additional claims come in, but unfortunately, the last few months have not been great. It has been higher. It's not like outrageously bad, but it does impact when essentially costs are expected to increase at 7% and the funding's 3.4% in this case. Okay, next slide, please. So this is just kind of showing each year on a bar basis the cost versus funding. You can see for 24, it was pretty close between the two. 25, a little bit of a delta, where the funding is expected to be a little bit lower than the cost. And part of that was due to the board, using some reserves to make MODA and Choice low-cost plans. So that was part of what the board elected to do last time. And so that does result in a little bit of a deficit. But then you can see for 26, costs are projected right now to be a bit higher than the funding. And then 27 and 28, that delta continues to grow. Okay, next slide. So the historical cost increases. This is something that we've kind of shown where PEBB has been meeting at 3.4%. over the long term. We shifted it over a year. You can see the impacts of the pandemic in 2021. That should say 20. Well, the numbers are a little bit off. Anyway, so but overall, you had been meeting it until 26. So 25, the costs are coming in a little bit higher. It's a little bit above the 3.4%. And then now with 26, we're expecting about 7%, 7.2% increase. And so that starts, start now getting to the point where essentially PEB is trending pretty close to the market trend, and that without any changes, and that does impact how PEB looks against the 3.4%. Okay, next slide, please. So this one kind of shows the impact of if you do make changes to meet the 3.4% for 26. While that does help, it or actually, this is not 3.4% in 27, 28. Sorry, my apologies. So while that does help, you still need to make changes for 26 in order for the funding balance not to really fall below the target. So essentially what this shows is even if you left things the same and you bought down, but you made changes in 27 and 28, you would be below the reserve target for 26, and then it still continues to be below for 27 and 28. So essentially deficit spending is going to be over the next few years. Even if you make some changes in the following years, you're going to still be below the target and potentially put the PEB funds where maybe potentially the cost could come in and there might not be enough money to pay for it if you have a really bad year. So it is kind of a little bit of a word of caution about there might need to be some changes in order to make sure that the stabilization fund ends up in a relatively healthy place in the future. Okay, next slide. So just some of the data and assumptions methodology here, I won't really talk about. We do use updated claims through 25 and decisions in 20 claims through December of 24, apologies. And we do have the renewal decisions in 25. Nothing for 26 as of yet. We do have the self-insured rates in there, or expected self-insured claims. For Kaiser, we did not have the round one rates yet. So we did assume essentially 7% for medical and 4% for dental. We'll see if the rates come in there. Right now, preliminarily it might come in a little bit higher. So that 68 million, unfortunately, might be a little bit higher as we get the actual Kaiser round one rates, and just some additional information there on the right that I think we've talked about. Okay, next few slides I believe are just kind of like the numbers in a little bit more detail. On the appendix, including, so this is the numbers behind the market trend rates, and so you can see the exact pennies on where the costs are coming in versus the funding, and then the surplus deficits, that line in blue, so you can see the $300,000 on the left for 24, and then it starts growing as we go on, and then the ending stabilization fund there on the right, on the bottom column, the green unfortunately does get negative in 2028. And then the next slide, I think, is the 3.4% cost growth, where we hold 27, 28 at 3.4%. Stabilization fund does end up higher, but that does require changes in 27, 28, and then assumes deficit spending for 26 at this point. And then next slide. I think the next two slides, it just shows the targets, the risk-based capital targets in this case. So just the different plans and the targets that we assume for each of those. And that's actually the presentation. I will pause here to see if there's any other questions or comments before we move on. Ali?
Thanks, Emery. Yeah, just a quick comment. The governor's budget for the 2025-27 biennium that the legislature is now hearing and considering did not include any transfers out of the PEB stabilization fund, like that 90 million that you saw earlier. So so far so good going into next biennium. But yeah, it's it's been a difficult several months, like Emery mentioned. The board's done a good job managing finances. This is the first opening round of the renewal. So, the picture has the opportunity to get a little bit brighter over the next couple of months. But yeah, the PEBB board's in a position financially where it hasn't seen itself in the last few years. So I think Emery covered that quite well. Thanks.
Oh, great.
I guess a question for Ali. Is there a time or is there something we're looking at where we can speak with legislation and let them know basically kind of what, I mean, I know, every now and then, I don't know if it's, you say it's not in the budget, but we don't know if they'll turn around tomorrow and say X. So I don't know if there's just, some time when or if you need me or anybody to, chat with them and sit down in any kind of a budget hearing or anything and say, hey, this is where we are. This is where, we need you guys to realize what's going to, where we're at and what's happening basically. And if so, I guess I'm offering up to let me know because I will definitely be there.
Yeah, thanks, Greg. You're absolutely right. I mean, just because it's not in the governor's budget doesn't mean the legislature won't do something on their own. So, yeah, we do have communications with our legislative fiscal office and as well as the executive CFO's office. And so we would share the same information to them. And, I think I think if we see that there's any seriousness behind, I mean, when they did that $90 million transfer, there was a lot more above the surplus at that time in stabilization, so didn't reflect the picture that we're looking at today. So hopefully they would take that into consideration.
Okay. Are there any other questions or comments before I turn it back over to the chair? Okay. Thank you.
Thank you, Emery. That's a good question, Greg. And we do often have Rep. Nose with us also as a conduit of information for the legislature, even though he is still not with us today, to my knowledge. So it's a good question, and Ali, we will be standing by for communications from board staff if there comes an opportunity or the need to show up there.
Another thing, I guarantee you that, this is all of the union's members' insurance. And I guarantee if we definitely could get ASME, SEIU, and them on board to go in right there beside us and say, hey, this is, our members need this and we can't be doing what we've done before. So.
Thanks, Greg. Siobhan, did you want to comment there?
Oh, I was just going to agree with Greg. Our union's monitoring this as well.
Okay. And Emily, I see your note in the chat. Thank you. Okay. So with that, thanks for helping me stay on time. Thank you, Emery. That is something that we are going to need to work with actively here as we witness how the market is shifting and what we're working with. So thank you for helping give us the tools to think about it. We'll turn now to a market update on GLP-1s, another opportunity to break the bank for lots of different organizations and payers. GLP-1s are still early in their life cycle in clinical practice, and I look forward to hearing about how the market is coming along. Sarah Drake with Mercer, are you with us?
I am. Thank you, Chair.
Thank you.
So that was a great introduction. I know we talked extensively about GLP-1s over the last year and through the summer with CL. We wanted to bring an update on GLP-1s to the board this month to review everything that's happened in the market over the last year, and then also just reaffirm the board's direction. We know that this is an important topic for the board. We know that this is an important topic for the members, and that's why we're continuing to monitor. So as we'll go through this, I want it to be interactive. If you have questions, please raise your hand as we go. We can go to the next slide. This is just an overview of some of the things we're going to go through. And we can move to slide 4. Some of this you've seen before. We know at this point what GLP-1s are, how they work, and what they do. We've been talking about them a lot in the context of diabetes and in the context of use as an obesity treatment agent. Other thing to note is they're also being studied in a lot of other chronic conditions, and that what we're seeing is it could expand the use of GLP-1 significantly over time, regardless of what actions the board might take to add coverage for obesity treatment or not. Over time, we're going to likely see additional indications and additional chunks of people who might be eligible for treatment with GLP-1s as the drugs gain additional research support, additional indications. Let's go to the next slide. I wanted to show some updated data on what employers are doing in terms of covering medications for the treatment of obesity. And so this data comes from the Mercer 2025 employer survey. This is our newest in-house data. And we were able to break it down on the left pie chart. That is government employers that have 500 or more employees. And what you can see, as of today, if you look at the light gray and then the light blue, those are employers that are not currently covering obesity treatment. The light blue are considering it. And whereas in green, both the light and the dark, those are the employers that are covering. So what you can see is actually most government employers are not covering obesity treatment at this time, similar to the position that PEBB is in. The middle is specific to state governments, and similar results there. A little over half of state governments are not covering, that responded to our survey, are not covering obesity treatment medications. And then on the right, those are all employers, not just government. So all employers in the West region. And what you can see there, again, is this is pretty close, right? So about 55% of employers are not covering currently. 11% are considering covering, but haven't made an action to do so yet. If we go to the next slide, this one's really interesting. This one comes from, it's called the Leverage Obesity Coverage Nexus. It's funded by the Robert Wood Johnson Foundation, and they maintain a website that shows coverage policy for obesity treatment across all different payer types. And you're able to filter it just for state government employees. And so what you can see here is by state in pink, those are the states that currently do offer obesity treatment coverage for state employees. States in the dark blue do not. So you can see in Oregon, you're in the majority of states, but you can see which states currently are covering. I wanted to go to the next slide and just talk about a few things that have hit the news around state government plans for obesity treatment medication. So I think we talked last year about North Carolina. They eliminated coverage effective April 2024. What they were seeing is about 3.5% of their enrollees were filling prescriptions for GLP-1 medications for weight loss, and the cost accounted for 10% of all their prescription drug costs. They estimated the cost to continue coverage at $48.50 per member per month, and that was the reason they had to stop. Delaware recently added coverage. They added coverage in 2023, and they expected to spend $1.8 million. That was a little bit underestimate, I'd say. What they found was for 2025, they're expecting to spend $52.5 0.8 million. So the cost just really ballooned compared to expectations. Colorado is another state. They began covering GLP-1 for weight loss in September of 2022. And unfortunately for them, the cost became unsustainable. For the 6-month period, July through December 2023, it was about $1.5 million in spend. The next year, it was up to $7 million in spend. So as a result, the state has announced they're eliminating coverage for obesity treatment effective July 1st, 2025. There's coverage is still going to be available for the other indications such as type 2 diabetes, but not for obesity treatment. And then New Mexico is projecting an $85 million budget shortfall, and they've announced a 29% premium increase for 2026. The GLP-1 costs are expected to be over 20 million, so it's a significant portion of their budget shortfall. So I think as Dawn's comment earlier, these drugs are creating challenges kind of across all of the state governments as well as a lot of other employers. Let's go to the next slide real quick. Just wanted to bring up there was a CMS proposed rule that was issued at the end of the Biden administration that effectively would have required Medicaid to cover obesity treatment medications. And it would have allowed Medicare to cover obesity treatment medications. With the new administration in place, they would need to finalize that rule. At this point, we don't know what's going to happen there. Given the new administration, there's a new HHS secretary. So for now, this is just sitting out there. There were public comments that came in, but we don't know where it's going from here. But if that would have moved forward, we would have seen a lot more access through the Medicare and Medicaid channels than what we currently do. Before we go into pricing, just any questions or comments on some of this data and information? All right, let's keep going and talk a little bit about pricing.
Sarah?
Yeah.
Me. Hey. My question is about whether if you go back a slide, please, or two. The question is whether they're being covered for obesity or for other things. And I think that the possibility of covering, it's not clear to me in each of these conversations, each of the slides, whether we're talking about only for obesity or for other indications, because there are some ways that we're already covering it. For example, for EPSDT, early periodic screening, diagnostic, and treatment programs for children through Medicaid, just as an example, because we have to, it's mandated. And we use prior authorization, and it's a slender slice of, I think, all the people who might be eligible for any of the indications, including obesity, because we're using it only for a very focused set of diagnoses for which potentially the outcomes are better established in the data. And I look forward to getting to that part of the conversation as well.
Yeah, absolutely. And we can talk about that a little more for indication update, but just as of today, PEBB does cover GLP-1s for treatment of type 2 diabetes. You'll also see that the carriers there's a difference between the carriers, but some of the carriers are offering coverage for the cardiovascular risk reduction indication. And for the obstructive sleep apnea indication for people with obesity. As far as Medicare, as of today, Medicare covers GLP-1 for diabetes, and they also are allowed to cover for the other indications, but they're not required to. Medicaid has the option. EPSDT is kind of a unique, that's for children. But outside of the EPSDT population, so in adults, states have the choice to cover for obesity treatment or not. And that's, I want to say it's maybe a fourth-ish of states are covering for obesity treatment. But the states are required to cover the other indications. So the obstructive sleep apnea and the cardiovascular risk reduction, states are required to cover those indications in Medicaid. Did
Thank
that
you for
kind
that
of
reminder.
answer your question?
Yeah.
Okay.
Yep. Thank you.
All right, let's keep going and talk about pricing. I was hoping to have better updates here this year, but I don't. The current pricing, we really haven't seen a lot of change since last year. The pricing has stayed largely the same, with the exception that Zepbound actually took a price increase on January 1st this year, a 2.5% price increase. The available rebates in the market based on the best data we can find have stayed about the same. They really haven't changed much. So the pricing of the GLP-1s for obesity treatment, unfortunately, there's not any big updates here. The pricing remains the same. It's between about $1,100 and $1,400 a month, depending on the specific drug and dose. Let's go to the next slide. There is direct-to-consumer pricing available. So for people who want to access these medications outside of their health plan, each of the manufacturers does offer direct-to-consumer pricing, either through their telemedicine pharmacy or through a discount card that can be used at the pharmacy. So Wegovy offers pricing of about $650 per month. Zepbound offers also $650 per month. But they also offer direct to consumer through Lilly Direct. This is their mail order pharmacy. They have vials rather than the pens that are available for about $400 to $550, depending on the dose. Unfortunately, the doses that are available through Lilly Direct are the lower doses, and those aren't the doses that have proven most effective for weight loss. And so, even though it's a lower starting price point, the price point for the maintenance tends to still be that $650. Saxenda is the older product. That's the once a day product rather than the newer once a week products. It doesn't work as well as Wegovy and Zepbound. And interestingly, Saxenda doesn't offer any kind of direct to consumer savings card offer, but they're made by the same manufacturer that makes Wegovy. And so if you go to the Saxenda website, it will actually direct you to the Wegovy direct to consumer offer. Let's keep going. Just another question mark here. Ozempic and Wegovy were included on the list of 15 medications that would be subject to the next round of Medicare price negotiations. At this point, we don't know what's going to happen with those with the new administration, so it's something that we'll continue to watch. But there's potential if there could be a change in pricing as a result of the Medicare price negotiation. It could end up potentially being beneficial to plans and members, or depending on how the manufacturers react, it could result in prices being lower for some of the government channels and higher for some of the employer channels. Again, we don't know where this is going to go, but we're going to continue to monitor. What does this mean for PEBB? Let's go to the next slide. So I think you've already seen Emery's discussion on some of the challenges facing PEBB. Add this to the list. So we've asked, and we continue to ask each of the carriers, what would be the impact of adding obesity treatment drug coverage to the plan, and the approximate response we've received is 2%, and that would be adding coverage of the medications consistent with the FDA label, and there would be, and that's even with rebates and discounts available. So that 2% continues to be a challenge, just in the context of everything else that is driving costs for PEBB. Any questions on pricing before we get into some of the new indications?
I have one. 2% is hard for me to compare to like the $48 PMPM and the difference that Delaware saw between the 1.8 million that they projected and the 50 million that they're seeing in terms of expenditures. I don't know if it's you, Sarah, or if Emily would want to speak on how this 2% fits into that span of the struggle that they've been having to adequately project the costs associated with these drugs, which might have amazing health impact, even as we are early in the trajectory and don't have long-term data yet.
Yeah, Emery, do you have a comparison of what does that 2% mean in terms of dollars?
Yeah, it's roughly $15 per member per month for the 2%. So it is lower than what Delaware was, did see, or is projecting at the 58 million. But there is definitely, I don't know what the, the impact, overall impact. I mean, there's definitely a lot of GLP-1 spend for PEB right now. That I don't know if it's in California, Delaware spend, but it is lower than what Delaware's saying, but it is a lot of money.
Thank you.
I will say I've yet to run into a case where projected GLP-1 spend was overestimated. Pretty consistently, I've seen across my clients, there's an estimate that comes from the PBMs or the carriers, and then the actual utilization and cost, it ends up higher. I think everybody is still wrapping their heads around what the range and the demand and the need is for these medications, and it's difficult to project accurately still.
I wonder if people come out of the woodwork when this gets covered, so we don't have BMI data on them, so it makes it harder to project. Sean, I see your hand is up.
Yeah, just anticipating that comment, really. I was just thinking like 15 seems low. Like, just for precautionary principle, it seems that it would be more reasonable for us to estimate somewhere between 45 and 50. Since that seems to be the actual real world. But yeah, just restating, you comments just said this, which is basically like whenever the plans for whatever reason estimate, they always are estimating way low, and it seems so. I'm taking that 2% with a more like a spoonful of salt there. So maybe for our planning, maybe we should just go ahead and pencil it in at somewhere around 45 to at least be in the ballpark of what other state governments have experienced.
I mean, as you'll
$45
see,
PMPM.
I will say, as you'll see in some other data, Oregon is situated somewhat favorably in terms that you have a lower prevalence of obesity than some of the other states. And so that is an advantage for you, and that it's, even though the prevalence is growing, it's less than what some other states have experienced, especially states like, North Carolina. I don't know Delaware off the top of my head, but yeah.
Yeah, I was gonna say not to Delaware though. I wouldn't think that we're like leagues different than Delaware. So North Carolina maybe. I mean, for sure, I would believe that. Yep. When you look at just like obesity maps, it's like, the
Right.
deep south, right? But then
Yeah.
the tops of the two coasts are generally the lower. So I wouldn't think Delaware is way out of our range.
Thank you, Sean. I agree that the grain of salt and the understanding of that is something that we would have to pay pretty close attention to and understand pretty well. Any more questions? Or Sarah, you ready to go on?
Yeah, let's talk about some of the new indications briefly, just to give an update on what we've seen over the last year. So Wegovy received FDA approval for a secondary cardiovascular risk reduction indication, and that means that it was proven effective to reduce the risk of a cardiovascular event for people who had already experienced a heart attack, stroke, or symptoms of peripheral arterial disease. It does offer a modest risk reduction benefit in overweight or obese people that have experienced one of those events. The challenge is at the current pricing for Wegovy, the cost to prevent one major event, it exceeds $3 million at the current dose. And that remains the challenge for the new indication. Let's go to the next slide. I talked about this previously, and again, there's kind of an open question of what's going to happen with the new administration. But as of today, Medicare is allowed to cover the new indications under Medicare Part D. Medicaid is required to cover the new indications under Medicaid. So the government populations do have access for these new indications, but not for obesity treatment unless Medicaid has chosen to cover for obesity treatment, and that's optional. Let's go to the next slide. Other new indication, this one's hot off the press. In December of last year, FDA approved Zepbound for the treatment of moderate to severe sleep apnea in adults who have obesity. What's interesting here is in the clinical trials, the participants that were using the Zepbound, they did lose an average of 45 pounds and then also experienced a significant reduction in their breathing interruptions during sleep. Even in the press release from FDA, the improvement in their sleep apnea symptoms is likely related to body weight reduction with the Zepbound. So somewhat unlike what we're seeing with the cardiovascular risk reduction, where there could be some kind of independent effect where the drug is improving cardiovascular profile outside of the weight loss itself. With this sleep apnea, it really appears that it is the weight loss that then is improving the sleep apnea, and the Zepbound is a tool to achieve the weight loss. For those of you that aren't familiar with sleep apnea today, the clinical guidelines recommend conservative therapy first, prevention, things like stopping smoking, lifestyle change, sleep hygiene, and then mechanical measures like CPAP and BiPAP. All the information I've seen so far is that CPAP and BiPAP would continue for people who would use Zepbound for sleep apnea. So it's not like a replacement for the CPAP and BiPAP, which I know isn't popular for people that use it because it's a big mechanical thing. Let's go to the next slide and talk about what your carriers are doing today based on the most recent information we've been able to get. So MODA does offer Wegovy via prior authorization for the cardiovascular indication that was effective in September. Zepbound will be available through prior auth for members who meet the requirements. So they're offering both Wegovy and Zepbound for the new indications. Rebates are not available unless all indications are covered, including the obesity treatment indication. So as of today, any medications that are approved for Wegovy and Zepbound for cardiovascular or sleep apnea, they will be at full price and there won't be any rebate through MODA. Kaiser has said that the Wegovy can be covered for cardiovascular risk reduction if the provider deems it medically necessary, and they're still reviewing the Zepbound new indication. From Providence, what they've said is Wegovy and Zepbound will both remain on benefit exclusion unless PEBB makes a decision to cover. So as of today, there's not a pathway to coverage through Providence. And Providence said the same thing. Rebates are not available unless all indications are covered. All right, let's move on and talk real quick about the pipeline. I don't want to spend a ton of time here, but mostly just want to note that there's additional research going on in the world of GLP-1, and we're likely to see additional approvals for other indications, probably in the near future, especially in 2026 and beyond. And you'll see the range of conditions that are being tested here is growing quite a bit. We're moving away from kind of the traditional diseases associated with obesity, like MASH or the metabolic associated liver disease, into things like Alzheimer's disease. And there's also studies going on for treatment of addiction or alcoholism. So a lot of activity on these medications. And then if we go to the next slide, Next slide is the pipeline of new products. So Wegovy, Zepbound are the beginning, but they're not the end. There's a lot of additional activity going on in research. We're not expecting too much this year for weight management, but coming in 2026 and beyond, there's going to be a lot of additional competition in the market. Many of us are hoping that this is where we'll start seeing some real price competition, and maybe that's when the prices could come down. And then if we go to the following slide, I want to highlight that GLP-1, we've all been talking about GLP-1, right, for obesity treatment, but it's not the only class out there that's being studied for obesity treatment. I think 4 to 5 years out, the toolbox available for treatment of obesity is going to look a lot different than what it looks like today, because there's all this additional research on different types of medications that work in different ways. Okay, let's go to the next section and talk about some new real world data that's out there. So this first slide I alluded to previously. This is some new national and state level prevalence data on the incidence of overweight and obesity. And this new study also includes forecasts up to 2050. So I think about this as a good news, bad news slide. I think the good news here is that a couple pieces of good news. One is the rate of growth of obesity and overweight is slowing, both in Oregon and in the rest of the country. That's good news. Oregon does have lower prevalence of obesity in both adults and in adolescents compared to the rest of the country. Also good news. But, the bad news is still that the prevalence of obesity and overweight is still very, very high across the country and projected to continue to increase to 2050, to the point that we're expecting over half of adults, in Oregon that could be overweight or obese by 2050. Let's go to the next slide. This is some new data on real world use of GLP-1. So I've got 2 slides on this topic. This first slide is about, it's a huge review that was published in Nature, and it looked at more than 2 million VA records. And these were people that were using GLP-1 for diabetes treatment. Oh, I think I see Sean has a question. I'm sorry.
No worries. So just on the pipeline question, I'm assuming that we're really far out from generics getting on board, right?
Yep. So the generic for Ozempic or semaglutide, which is the same active ingredient that's in Wegovy, is 2031. There is a generic expected for Saxenda, which is the older daily use GLP-1. That is expected, I believe, next year, 2026. Of course, the market share of Saxenda is like less than 1%. It's daily, it doesn't work as well, but that could be an option with a generic available relatively soon. But for the weekly products, yeah, we're looking at beyond 2030. Good question. Okay. All right, back to the VA study. So these were veterans that were using GLP-1s for diabetes, and they compared the long-term impact of the drugs against people that had not used GLP-1, and they found some interesting things. Some were expected, some were not. So they did find, expectedly, people who used GLP-1 had lower risk of some cardiometabolic conditions. Also some respiratory issues like obstructive sleep apnea, but maybe a little more surprisingly, they found people that were using GLP-1 had a reduced risk of neurological disease, including Alzheimer's, substance abuse, and seizures. So again, it points to maybe some of these other indications for GLP-1 as the research keeps coming out. Also, GLP-1s did have some risks, right? There was a higher risk of GI disorders, not surprising there. Also low blood pressure, kidney stones, pancreatitis, and interestingly, arthritis. And that one's a little bit of a head scratcher. We don't know if maybe people that were using these were able to be more active and were had more joint issues. We don't know, but that was kind of an interesting finding. Let's go to the next slide. And this is some other real world data. This came out of Prime Therapeutics. And so what Prime Therapeutics did is they look at claims from 16 million commercially insured members. And they identified members who were using GLP-1 that did not have a diagnosis of diabetes. So these people were presumably using it for treatment of obesity. And then they were matched with a control pair that had similar characteristics in terms of gender, age category, and other comorbidities. Their study actually ended up including about 3,000 members using GLP-1, and then they were matched with about 8,000 controls. About 81% were female, and the average age was 46. And what they found was that people that were using GLP-1 had a higher cost of care than people who did not. It was about $7,000 higher in year one, $4,000 higher in year two. This wasn't particularly surprising, but what it showed was that while there could be very significant long-term impacts of success with weight loss and cardiometabolic improvement, the savings doesn't happen immediately, and certainly not within the first couple of years, or not enough to offset the cost of the drugs. A few other interesting things came out here. The additional cost was lower the second year because more people actually quit using the drugs. What they saw was 32% of people who started it were still on therapy at 1 year, and 27% were adherent to therapy, meaning they were taking it regularly. After 2 years, only 15% of members were still taking the drugs, and 17% were adherent. We don't know the reasons for that. Was it cost challenges, high copays? Or was it side effects? We don't know. But again, it points to if people aren't continuing to take the medications, are they going to continue to keep the weight off? And are you going to get those benefits of reduced expenditures over time? And it's just, again, some of the challenge of GLP-1. Any questions or comments on some of the real world data? Okay, let's keep going. Just in the interest of time, definitely just wanted to highlight some ongoing equity considerations around GLP-1. We do know that people of color tend to be prescribed GLP-1 less for both diabetes and weight loss. We don't know the reasons for that, but it has been documented. And it has been seen even in instances like the VA health system where financial constraints shouldn't be an issue. If we go to the next slide. And this again, just highlights some of the concerns around health equity and some of the challenges that are facing people who have obesity who might be subject to some of the social determinants of health, like access to nutritional foods, stress, caregiving, lifestyle demands, all of these things are contributing to some of the challenges that people with cardiometabolic disease might be facing. Let's go to the next section and talk real quick about supply. We've all been hearing about the supply of these medications and some of the shortages. So as of today, Saxenda is still on the shortage list. Wegovy is still on the list, but it's reported as available. And then Mounjaro and Zepbound have been removed from the list. So the shortage is resolved, but you can see there's a long note there for every strength on the FDA website. And some of this has to do with some legal activity between the FDA and compounding pharmacies. So short story here, it appears that manufacturing capacity is up. These medications are available now in a way that they weren't 6 months or a year ago, and that's continuing to increase utilization in the market because it's easier for people to get the medications now. All right, let's go on real quick. Point solution landscape. So we've talked last year as we worked through CL, we talked about some of the different vendors in this space that exist to help with the lifestyle component of weight management. That can be paired along with GLP-1. We're continuing to see more vendors entering this space, especially in that GLP-1 box on the far right. And maybe even more interestingly, we're starting to see some of these point solutions are offering where they'll actually fulfill the prescriptions as well as, assist with the prescribing or managing the lifestyle. There's Digby Health is one. They actually will ship out brand name Ozempic. They also offer compounded, which we've talked before about some of the challenges with compounding. But I think we're starting to see where some of these vendors might offer direct fulfillment, which could present an option to get a drug at like a net of rebate price while still being able to put some guardrails around, making sure only the highest risk people have access to the drug first. So that could create some opportunities, and that's something we're really watching closely. This is new, just in the last few months, we're starting to see. All right, and then let's go to slide 35 and just talk about where we are now and what our renewal approach is. Oh, Sean, you've got your hand up.
Yeah, quickly, just glancing over some of the names in that previous slide, not to get, so this is a brief question, but it sure seems like there's a market opening for someone to have a business that has something to do with delivering food, like prepared food or whatever for people that are type 2 diabetes or losing weight or this or that, because it would be like a tenth of the cost, literally if we just paid for everyone's meal, it would still be cheaper. So, and I just seeing some of the names were kind of like Food Smart and like, Fruit Tree or whatever. So I'm just curious, like, have you seen anything in that direction, where it's sort of like, what is it called? Prescribed, food is
Oh, like
medicine or something, whatever.
food is medicine.
Yeah,
Yeah.
yeah. Like, because it's getting so expensive to do this, like, is there a vendor that you're aware of that's just like doing that as like the last ditch effort before you like, you know, use both barrels, break the bank on the prescription or anything like that? Just checking.
That's not something I have seen. I don't know if Christy is on, if that's something that our Mercer Well team has run into.
Hi, Sarah, I'm here. It is, as far as what we're really seeing in the market is the hospital systems are really offering food as medicine, more as a prescription, and then you can get it to your home. Food Smart, as you mentioned, Sean, is a vendor that's been in the market for a while, and they offer kind of grocery services as an employer paid benefit. There are some tax implications that I would ask maybe Andrew or Emery, but I believe that we've looked at it a little bit, and it is considered a benefit that would fall under being taxed. So that kind of has been a little bit of a barrier for
Yep.
coverage.
We can discuss the details later. Like, I didn't mean to open up a can. I was just curious, like, is it a thing? Has anyone tried it? It sounds like maybe uh discussion for later, but I appreciate it. I was just looking for options as we're staring down the abyss here. Thank you.
Great question. Thanks, Christy. So this slide just has where we are today, and this is what we really wanted to affirm with the board. So part of the renewal process, we are asking the carriers to provide estimates for different scenarios of adding obesity treatment coverage, including GLP-1. Also planning to include questions in the RFP, both about GLP-1 coverage options and potential programs and structure. So things like lifestyle management programs that could be paired and integrated with GLP-1. The ultimate goal here is we're seeing it is to add coverage when the pricing becomes sustainable for PEBB. And we can continue monitoring the market, the coverage landscape, and then just explore those additional options with you as they become available. And so just wanting to reaffirm with the board that this is the direction that we're taking and that we recommend that we take, given what's happened in the market over the last year and where PEBB is today with some of the funding challenges.
So it seems like it's walking a line between a variety of pressures on the system. And so I appreciate the thoughtfulness of the approach. I don't think we actually have an action associated in terms of a vote here for the board, and as you're coming for reaffirmation, I don't think we're set up to take an official vote on it, but this does seem in alignment with the approach that we have been discussing and developing over time, and I welcome any board members to speak up if you disagree or agree. Okay, thank you, Sarah, for the good information, for the reminders about context, what's already required for which programs, et cetera, what's already being covered. Good context and good grounding. Thank you for coming back with an update.
Thank you.
I don't think I have any redirection to offer. I think you're on the right track from where I stand. We can follow up afterwards if others feel differently. Thank you. And with that, I think we have come to our break for the morning. Let's go ahead and, those are additional slides that are included in the packet for compounding for our review. Am I right about that, Sarah?
Yeah, I included an appendix about compounding just in case it came up. Short story there. You probably saw the ad on the Super Bowl about compounding, but despite that, there remain some regulatory challenges. It's kind of a legal gray area. FDA could start enforcing against compounders now that the shortage is resolved. Whether or not the new administration is going to pursue that, we don't know. But it's something that we're continuing to watch. I did see something in the news, it was on NPR just in the last week, about there's one of these online telemedicine services that was contracting with a compounding pharmacy. Turns out that pharmacy was not licensed in the state it was operating in. So, these are the kind of things that are challenges with the compounders, again, because it's kind of a regulatory gray area, especially with the shortage being resolved.
Thank you. Okay. Thank you for that presentation. Let's go ahead and take our break now. Let's come on back at 10:50 and we'll get into the round one renewals. Please take a break, get up and stretch.
Good morning and welcome back. PEB members, if you have returned, please feel free to come on camera. Let me know that you're back. Hi, Siobhan. Thank you. Ali, nice to see you. Thank you for being here. Chicky. That Emily, hello.
Kimberly.
Kimberly, thank you. Do we have Sean and Greg? There's Sean. Hi.
I'm here.
Thank you. All right, that's quorum. Let's go ahead and get started. Andrew, I think it's over to you.
Yes, thank you, Don. Good morning, everyone. I'm glad to be with you as we start to talk about Round 1 renewal responses. So we will be doing that over the course of the next hour or so. And so we'll look at the preliminary proposals from the carriers, and we'll build on some of the things that Emery has talked about with regards to PEB's financial position. And just as a reminder, this is round 1 of likely 3 rounds. And so we will be back with you over the course of the next few months to continue this discussion, continue refining options and negotiating with carriers, and ultimately making sure that board members, you're all adequately informed to formally approve any changes for the 2026 plan year. That will not happen today, so no formal votes today, but that is sort of the direction that we're heading in, again, over the next couple of months. So if we could proceed to the next slide, I'll just make a couple of quick comments here before we launch in to get you oriented to what we're going to be talking about. And so with this first section, this is just to sort of get regrounded in some of the things that we've talked about with regards to the focus for this renewal. And so we'll spend a couple of minutes there before we switch over to section 2 and start talking about your self-insured claims experience. For your medical, dental, and vision plan, so we can see what those claims look like compared to the budget that was set in the 2025 rates, which will inform the cost projections for 2026. We'll spend just a very quick moment in section 3 looking backwards at some of the decisions that you all made last year and some of the implications for the plan moving forward. And then in section 4, this is where we'll probably spend most of our time. Part of it will be an update on financials, and so we'll have an aggregate financials perspective, as well as a slide on the composite rate, so that we can provide a little bit of context on the dollar amount that we are currently over 3.4%. In that section, we'll also talk about some of the preliminary proposals from the carriers. We'll spend a couple of minutes talking about the Canopy EAP renewal. This is one of the benefits that renews off calendar year. It does have a 7/1 effective date. And so we'll carve out some time to talk about that, and then likely ask board members to vote on that renewal this time next month in March. Yeah, after that, we'll wrap it up with next steps, and go from there. So if we want to go ahead to slide 4, please, Rose. This is a slide that you all have seen, so I'll do it really quickly. This is just an acknowledgement to this idea around this year being a little bit different from prior years in terms of our renewal process and our focus, given the medical and pharmacy RFP, which we're working on concurrently. And so there are obviously some unknowns related to the RFP. We don't know which carriers will be awarded the business as of 1/1/27. And so the approach that we had agreed upon was for this renewal for 1/1/26. There will be less focus on looking at new subcontracted point solutions, other sort of vendors that might fill a niche space and providing some sort of support service. And instead focus just on the current ecosystem. Still look at all the things that we look at every year around, enhancements to member support. How can we deliver care more efficiently? All of that good stuff that we go through, just with the caveat that we won't be looking at new subcontracted vendors for 2026, given the RFP, which will go live 1/1/27. And so the goals for this renewal are similar to the RFP, and we've listed those four there. Obviously, focusing on equity, focusing on improving the quality of care that's delivered, financial stewardship with regards to meeting 3.4%, but also maintaining affordability for members, and focusing on the member experience and talking about how we can enhance that as well. And so if we jump to the next slide, this is another one that you've seen. So really just we'll give it a couple of brief comments before we move on into some of the sort of meat of the presentation. And so this is the values on the left and some key questions on the right. This is one of the work streams where board members are expected to make a lot of decisions for the upcoming plan year. And so hopefully these questions on the right will be a helpful resource for you all as you navigate some decisions which are not always black and white. And so hopefully that's helpful for you. But again, this is not a meeting where you'll be expected to make any decisions. This is really, we're in the information gathering stage of our renewal workstream process. And so our goal is to orient you on where we're at and make sure that you're as informed as you need to be to ultimately make decisions in the next 1 to 2 to 3 months. So I think we can jump to the next slide, which is an overview of all the carriers that are renewing 1/1/26, with the exception of the 3 that have a pink star. And so the standard life and disability is in a rate guarantee. Canopy EAP, I mentioned, that's a 7/1 renewal. And so we will be talking about that one, but it is an off-calendar year renewal. And then Unum, which has your long-term care policy, that one doesn't really renew per se. It's sort of an ongoing agreement. And so there's nothing to discuss and no decisions to be made at this point. And so just wanted to call that out. And so we'll be talking about the rest of these vendors today, with the exception of Weight Watchers, which we'll bring forward this time next month. Any questions so far? I realize I went through those a little bit on the quick side, but I know some of these messages and topics are things that we've talked through, but I do want to pause and see if there's any comments. Yes, Emily, I see you have your hand raised.
Yeah, for Unum, just following up with my question from last time, did we find anything out about them denying that coverage to our members based on pre-diabetes only?
I think we did have some back and forth on that, but I don't remember where it was resolved. And so I apologize for that. Let us see if we can pull that up here behind the scenes. And if so, we'll put it in the chat. And if not, we can quickly follow up with you. But I do recall that question. So thank you for bringing that up.
Okay, thanks.
I definitely don't want to lose sight of that. Okay. So not seeing any other raised hands, so I'm going to hand it off to Emery to talk about how the claims are coming in relative to the accrual rates, and let him talk about how that informs our cost projection for the upcoming plan year. So Emery, I'll pass it off to you.
Thank you, Andrew. I think, did give you a little bit of a preview of at least the medical costs here in the RBC presentation. But if you take a look, what we show are the monthly claims and admin amounts, and compare it, and also the loss ratio, compare that to the loss ratio. So essentially 100% would be perfectly projecting the cost for that month or that year. In this case, we are showing statewide, and if you kind of look essentially on the right half of the chart, you can see a lot of those loss ratios are above 100%, and if you compare that to the left side, those were below. And this is a common theme that happened in talking about, the last few months have been higher costs in terms of medical. And so overall, for statewide, it did end up in a surplus position. So there was about a $10 million surplus on overall about $338 million in claims. So the loss ratio came in at 97.2%, or about 3% below what we had projected. So statewide ran a little bit better than what we had expected or projected. And although that loss ratio was a bit higher than where it came in 23, which was at about 94%. The next slide, please. So this is where the news unfortunately starts getting a little bit worse, and you start seeing red numbers in that deficit position on the right. So again, the claims did increase quite a bit in the second half of the year for Providence Choice. Loss ratios in about 110 to 115%. And overall came in at about $8.5 million deficit on 342 million claims. So that ends up being a loss ratio of 102.3%. 2.3%, 2% above what we had expected, and a bit of an increase over what the loss ratio was for 2023. Next slide. For MODA, kind of a similar story to that of Providence Choice. Deficit came in about 4.1 million. Their claims were not quite half, a little bit more than half, 2/3 maybe, of Providence Choice at $211 million. So their loss ratio was pretty close, 101.8%, so not quite 2% above what we had projected. And again, that was an increase over what the loss ratio was for 2023. Okay. So that was the story in the medical. As you can see, 2 of the plans did run up in the deficit position, and the overall cost were overall deficit was a bit higher in total than compared to in total in this case. Okay. So for dental, the deficit there on the right was only 800 or 89,000, so not quite 100,000. So that ended up being a loss ratio of 100.2%. So if you take a look, the loss ratios were a bit higher in the first half of the year and kind of moderated in the second half of the year. So pretty close to projection, and just a little bit of an increase over 2023. And then better news on the next slide, which is the vision slide. So if you take a look, this is pretty typical in terms of the slope of the loss ratios. You have members using their benefits in the beginning of the year, so in January, and then realizing it's the end of the year, and so we must use their benefits again. And so higher benefits in December in this case. Overall, it did come in as a pretty healthy surplus, about 1.1 million for vision. Overall loss ratio was about same as 23 at about just under 91%. Okay, so that's the self-insured experience. We do not show Kaiser, but we'll see once the final experience comes in and the renewal rates come in for in round 2. Next slide, please. So taking a look, and this is just a recap of what happened last year. There were some changes to achieve some savings, about 4 million, most of it in the Providence health plans. So that was about 4.3 million. MODA was 500,000 savings. And there were some enhancements on the Kaiser plan, which actually resulted in increased cost. To kind of offset that increased program changes, there were some plan design changes for Kaiser traditional HMO, where the RX copays were increased to help defray some of the cost and to meet the 3.4%. And then on the right-hand side, again, the using of the reserves to buy down Choice and MODA to be low-cost plans, because the premiums that were being calculated were actually not quite the 10%, being 10% less than the statewide plan. So overall, about 21 million in savings to help meet that 3.4% limitation. Okay, so while this is kind of like a review of the prior, in the next few slides, we start moving on to what we're seeing for 26 and beyond, or for 2026. So looking at the renewals, this page shows essentially all of the plans, the medical, dental, and vision plans, as well as the administrative fee increases that were proposed, and then preliminary rate increases and the total premiums there on the right. Just to note, Kaiser, again, the Kaiser Medical and Dental, we do not have the rates quite as of yet. So we do have a 7% and 4% increase for those respectively. But starting at the top, the Providence statewide plan, our rate increase is about 7.2%, which is really close to what trend would be in total. And so that's about 415 million in premiums. For Providence Choice, unfortunately, the increase is a bit higher despite the admin coming in at about 2.9, same as statewide. We're projecting an 11% increase, and the total premiums are a bit higher than statewide at 425 million. Skipping the Kaiser line, let's going down to the Moda Medical. The admin fee increase proposed is again 2.9%, so essentially the same as the Providence plans. The rate increase right now is 11.6. Similar to Choice, where the costs have been coming in higher, and that those two increases of 11.1 and 11.6 do include the essentially the reduction, the buy down to make them low cost plans before. So the rate increase you see here is essentially trend and claims increase plus the offset of the rate buy down to make them low cost plans. For dental, Moda Dental of Oregon, we're at 3.4%. The loss ratio again was about 100%, so it's pretty close to trend with a admin fee that's coming in below 3.4% at 1.9. And then Willamette Dental Group, the next second from the bottom. So their admin fee is holding flat, but overall the premium the premium rates for them based on experience and what they're proposed, which does include, at least at this point, a little bit of a rate concession, does come in at 7.9%. The claims have been a bit higher for Willamette, and so this 7.9 is actually a little bit of a rate concession from, I believe, around 9% that was originally projected for that plan. And then for VSP, we are projecting essentially a rate hold or slight decrease in this case. So overall, PEBB's total costs about almost $1.5 billion for everybody. Okay, next slide. Taking a look at the ancillary kind of some fully insured benefits, the ASI Flex or the spending accounts, no rate admin fee increase there. BHS, again, no admin fee increase there. And Weight Watchers, right now, they're not proposing any cost increases, but we do have a little bit more detail. And so over that's 1.6 million. So all these programs in total is just a little over 2 million. Okay. All right, so with those rate increases, so how does it impact the composite? So let's move on to the next few slides. As mentioned below, I guess the bottom line is it's currently you're about $68 million above the 3.4% limitation. You can see at the bottom there in the table for 2026, the composite rate right now using the March of 2020, actually 2024. Actually, it's not the March, it's the January 2025. We'll update it with the March of 2025. But the composite rate's almost $2,000. It's $1,989, which unfortunately is an 8.4% increase above the final composite rate of 2025 of $1,835.71. So essentially, you are coming in about 5% higher than where the funding would be, and that's the potential size of the gap that needs to be made up in order to meet the funding in this case. We will update the final 25 number based on the March enrollment. As mentioned, we're in February, so we're now those numbers are we're just have the January. Any questions before we move on to the next slide? And so with that, I think I'll turn it over to Christy. Christy?
I'm here. Thank you so much. Sorry, getting my microphone and camera on. Hi, everybody. So I'm going to be sharing with you all the first round of our Canopy employee assistance renewal. And as Andrew said, this is an off-cycle renewal, and it'll be July 1st of this year. And so first, just to provide the overview of the services that are offered. With an employee assistance program, there's individual services, which includes that in the moment crisis line 24/7, 365 days a year. Also therapy, coaching. The PEBB agencies do get to elect the session model that they want to have, whether that's 3, 5, 6, or 8 sessions per event per year. One thing I just want to clarify here too is with per event, this is a very typical structure with EAP, and this just means that, for example, if a member were to, let's say, be experiencing a divorce in February and reaching out to the EAP for their 8 sessions, and then let's say later in the year in November, they're experiencing a high amount of stress from work that's leading to some anxiety, then they would get a new session count of 8 sessions. So that's what that per event means per year. We also have with Canopy a peer support program that is in place. And there is also a digital cognitive behavioral therapy program that is also in place currently. Also, there's organizational services that are offered to each of the agencies. This is critical incidents response, which is just if something is happening at the workplace, whether that's an external or internal factor, then a licensed clinician can be asked for to come to the workplace on site or virtual to provide individual or group counseling. There's also lots of trainings and education seminars and webinars that are provided, and then also manager consultation. So an ability for a manager to reach out and have guidance on maybe a challenging situation on kind of next steps. And then lastly, work-life services, which is such an important component of EAPs that offers services for members and their household members in the range of services that we have here on this slide. And so moving on to the next slide, as you can see, there is an EAP core fee for each of the session models. And you can see the first table at the top is the current PEPM fees by the different session models with that EAP core and then the peer support program additionally. In this first round, Canopy has expressed keeping the rates the same. And we're continuing to talk with Canopy about these rates, and a couple things is the peer support and the digital cognitive behavioral therapy programs. Those are both being looked at currently as part of the behavioral health vendor partner project that we're doing through CIAO. And there is pretty low utilization in the peer support program and the digital cognitive behavioral therapy program. So we're just working right now with Canopy to just talk about some different possible approaches to covering the costs of those programs. And we'll be coming back, as Andrew said, in March with some of the results of those ongoing discussions. Any questions on the current state of the Canopy renewal? Great. I think next slide is back to you, Emery.
I think it's to me for
you,
this
Andrew.
next
Okay.
one.
Great.
And so thanks, Christy. And so we're going to shift and start talking about medical. And so in this section, we'll start with the proposed administrative fees for your self-insured medical plans. We'll also spend some time giving you an update on CIAO and some of the clinical discussions that have occurred in that space and continue to occur and will continue to occur over the next few months. But first here with the proposed administrative increases, your self-insured medical and pharmacy plans are through Providence and MODA. And so you can see what they're proposing here. I'd call your attention to the light blue rows so that you can see in aggregate what the increase is that they're proposing. And so both carriers are proposing a 2.9% increase to the administrative fees. And so we have had and continue to have some back and forth with them around that proposed increase. But this is where we're at from a self-insured medical administrative fee perspective. And just to provide a little bit of context, when we think about your self-insured rates, the two primary components are your claims and your administrative fee, with the former sort of being the lion's share of what's driving cost. However, this is a component as well. And so when Emory does his cost projection and sets the 2026 rates, it will be claims experience plus these fixed fees for administrative components. Any questions on any of this? I realize it's kind of a busy slide, which is why I try to call your attention to the light blue rows are probably the most salient for purposes of this conversation, but I'll pause here and see if anyone has any questions or comments. Okay, and if not, I think, Chrissy, I'm handing it back over to you for a CIO update. And so my understanding, Chrissy, this is largely to get the broader board up to speed on the discussion. Obviously, 3 PEB board members participate in CI more regularly and ultimately will make recommendations to the broader board. I think the intent here is we want to sort of bring the broader board along so that they can know what all is being discussed and pose questions and that sort of thing. Is that fair?
That is great. Yes,
Okay.
agreed. Awesome. All right. So moving to the next slide. Just to kind of level set a little bit, as Andrew shared, last month in the initial renewal discussions, a few benefit options requests were included in the round 1 renewals. And CIO is evaluating the clinical effectiveness of these proposed healthcare services. And so in bringing this back to you all just to give you that foundation. So as in the next couple months making decisions, in this section, I'm going to review some of these benefit options with you to what is being proposed. One note also I just wanted to share is that we are still working on some of the health equity considerations for each of these topics. Our team is meeting later this week, and then we're also negotiating obviously the financials in the round 2 renewal responses as well. So the first item is menopause support. This benefit option aligns really well with PEB goals and 2 in particular of the member experience and equity. 33% of PEB's female population, 33% of PEB's population are female, about 26,500 members are of perimenopause or menopausal age. And really menopause symptoms vary, and it's a very individual experience. So we hear a lot about vasomotor symptoms like hot flashes and sleeplessness, but there's also muscle wasting, there's bone loss, increased risk of depression and anxiety, increased cardiovascular risk, and changes in metabolism. And so a lot of times studies show that these symptoms beyond the physical impacts also have a broad range of impacts on quality of life and also workplace productivity. We also know from the somewhat limited research that many healthcare providers may have a knowledge gap in understanding exactly menopause and its impact, and how to have these conversations in an empathetic manner, which sometimes can result in gaps in care. And so with this comprehensive support with resources and, the specialized training and knowledge that providers and coaches have around the topic of perimenopause and menopause, there's really the ability to talk through the ranges of options of treatments available to manage symptoms, the pros and cons of different treatments, also different lifestyle resources that are really specific to this age group and supporting the member in managing all of the emotional and psychological aspects. Under the equity goal, again, one of the key components here is that the specialized menopause program really does fill a needed gap in care. It does provide that specialized knowledge from providers, coaches, and the education and resources to PEB members across Oregon, rather than kind of relying on the individual knowledge of their provider. There's this additional resource available. As we move to the next slide, please. So a specialized menopause support program was asked in the round one renewals, and I'll just kind of walk through quickly here of what the carriers proposed. And so with Providence, they currently have in place for fertility benefits a vendor partner program that's called Progeny. Progeny does have a menopause program that they offer through some of their partners. And you can see here that the support of these programs have a patient care advocate. There is an access to the credentialed network of providers. So the National American Menopause Society does do a certification that providers, doctors, nurses, and nutritionists can undergo and get that certification. And so those types of providers are available. Virtual appointments within days, so that easy access, and then also prescriptions for hormone and non-hormone treatments. And again, addressing equity across the state so this program can be accessed by all members. In this table here, you can see for Providence, the member impact is about 9,800 eligible female members ages 40 to 60. And on the right-hand side, we've noted the impacts, but just keep in mind, this is the initial financial impacts, and then round two will have some differences. For MODA, MODA has kind of proposed the same approach where they have their fertility vendor partner in place is Kindbody. Kindbody also offers a menopause program. It is actually offered directly by Kindbody and has very similar supports as what I just went through with the Providence, where there's care navigator, there's specialized trained menopause practitioners, physicians. The prescription is available for hormone replacement therapy. And then additionally, MODA has these personalized coaching, which is 3 one-on-one sessions with coaches for nutrition, stress reduction, and other types of coaching needs that somebody might have. And then also just a really wide range of self-guided resources and educations available. The member impact is there. And then also on the right-hand side for MODA, I just wanted to call out that the case rate actually after a little bit further discussion at this point right now is at $850 case rate. And so obviously then that, that impact percentage there is going to change in the next month. And then for Kaiser, Kaiser with their integrated system does not offer a specialized menopause program. They really rely on their primary care providers to be that, offering that in an ongoing care. And, we do know just from the literature that there can be some knowledge gap with primary care providers in knowing exactly the specialized menopause services and being able to provide that to members. Okay, I'll move on then, please, to the next slide. Oh, Sean, you have a question?
Yeah, quick question. Sorry if I missed this. Would these be new offerings to Providence and MODA? In other words, do they offer these, do they already have a relationship with these vendors that they offer to some other clients, or would this be like a new thing for just for us?
I mean, so both of the vendors are already, in contract with MODA and Providence as their fertility vendors. So it wouldn't be a new vendor in that regards. I'm not sure if MODA or Providence have the actual menopause part of their offering in place for other books of their business, but we certainly could check on that and get back to you.
My real interest in that question was about integration, onboarding, that kind of thing. Like it often takes, from what I've observed, like a good deal of time for a new thing to come online effectively. So that was more what I was up to. So it sounds like they already have a relationship then. Okay, so that's good. Just asking.
Yeah, that's a great point. And they do already have a relationship in those. And again, Kindbody and Project are already in place for PEB members as the fertility vendor. So it'd really be, I think, relying on communication of recognizing that this menopause support is now also available from those vendors that are already in place. All right, and then our next category is the skin cancer screening. And so this was also identified by CIAO as a topic, as skin cancer is the most commonly diagnosed cancer in the United States. Typically right now, a visual skin examination is the most commonly proposed method for skin cancer screening. And yet, though, there is limited data on the clinical practice of screenings. It's not tracked a whole lot if these screenings are being completed, and a little bit more challenging to get some data on the rate of the screenings that are being completed. And so during the round one renewals, we asked the carriers each about skin cancer screening rates. And really the information received from each of the carriers was, really shows that there is a variety of educational resources and communications that are being completed. And then also we wanted to call out, there is through OHSU, there is a mole mapper app that allows the member to monitor moles and set self-exam reminders. So it kind of empowers the member to start tracking their moles and then bringing that to their attention of their primary care provider, which is really what is the current screening guidelines. A few of the opportunities that kind of were highlighted in this round one request of the carriers was, we could do more in integrating the OHSU Mole Mapper app across all of the carriers in communication and educational resources, promoting more of telemedicine for better access to care, and enhancing some resources and education on self-exams. And then also, and again, we do know that there is quite a wait time for getting in to see a dermatologist, and so making virtual and spot checks more widely available could also be a possible opportunity. Any questions about this topic before I move on to the next? All right. The final, oh, yeah.
So just to be clear, it's currently not a recommendation that people see their primary care doctor, like say once a year or something, in order to do a skin cancer screening, right? It's more of a self-exam kind of thing. Is that the situation?
Well, so the USPSTF that does make those recommendations did not see enough evidence to necessarily recommend the screening across, in a very formal way, but they do recommend that this is done by a PCP at a wellness exam. And that is in place. There's just not a lot of tracking to really know if this actually is being done. And oftentimes, again, what the literature really showed is that it seems like it is coming more from the member tracking. And when they go see their provider and they say, hey, this, something looks a little different here, and oftentimes that's how things are being tracked. But there is not that official recommendation from the USPTF at this time. They said there was not enough clinical evidence. There is some concern. I read the recommendation, and a lot of it came from some of the variability in skin color, skin tones, and some of those, especially with using sometimes different apps or different types of screening mechanisms with different skin tones. So at the time, they said that just was not enough evidence to make a formal recommendation. All right, we can move on to the next. So the last category I was going to talk about today is CIAO's vendor partner performance review project. Andrew did share some details of this last month. And so the focus is the behavioral health vendor partner programs, which are being reviewed first. We're compiling and have been compiling data from the carriers on each of these programs. And this data that we're compiling is going to be shared at the March CL meeting. So as you can see here, this process that we're taking is following the clinical strategy process, which is really just selecting, obviously, the identified area that we're focusing on, assessing, and then having some recommended actions that can be taken from there. We are currently, as I said, at the assess stage in this project, and utilizing the categories that are here at the right on this table. So under the assessment categories, we'll be looking at engagement and utilization, member experience, equity, and outcomes, which with each of these behavioral health vendor partner programs. The last column here on the right are some of the key metrics we're working on with under each of these categories. Now, not every single program is going to have these key metrics, but we just wanted to provide some examples of some of the key metrics that we'll be looking at and presenting at next month's meeting. As we move to the next slide, this really shows the vendor partner programs for PEBB that CIAO is looking at. So just to orient you to this slide is on the left-hand side is the carrier. The second column is those vendor partner programs that each carrier has. The third column, which it says in place, and it's got the green checks with the light blue shading, that just shows which programs are currently in place. And there are a few programs that are being proposed for this renewal cycle. And then the other three categories here are just showing kind of the focus area of those programs. And so I'm going to walk through these just pretty high level. So first is Providence, their behavioral health concierge program. This really is more of a treatment program. It provides in the moment crisis support, has same day, next day appointments with licensed clinicians, and is really meant for mild to moderate kind of anxiety, depression, stress. They will navigate to additional resources within the health plan if it is a more acute need. Providence also has TalkPlace currently in place. TalkPlace is a virtual national provider of counseling, medication management, and then also has some self-guided resources. And then lastly, for Providence, they have Charlie Health in place, which is a virtual intensive outpatient program. This is really meant to be a step down from like a residential program, inpatient stay, for somebody who maybe needs more support than just a traditional kind of outpatient relationship with a therapist. This is a step down of a virtual IOP program. It is for teens and adults. One interesting thing about Charlie Health is that they do have music and art therapy integrated into their virtual IOP program, as well as a wide variety of other therapy modalities. One thing I want to call out with Providence and also MODA is that they also have a provider in place called Equip, which is an eating disorder virtual program. They consider it a provider as an in-network provider, which is why it's not detailed here on this slide. But we will be getting some initial kind of engagement utilization information about that program as well. Moving next is Kaiser. So Kaiser has two vendor partner programs in place for behavioral health. One is Calm, which many of you might recognize that name. They do have a direct to consumer offering. It is an app with mindfulness content for stress reduction, sleep, and resilience. They also have some famous celebrities that have partnered with them as well. That makes it appealing. And then also Headspace. So Headspace started as a mental health mindfulness provider in the UK many years ago, and is now really built themselves out to be a pretty robust behavioral health provider. So they have their mindfulness, stress reduction, meditation, but they also have virtual therapy. They have text-based behavioral health coaching from board certified coaches, and also have medication management. And then lastly for MODA, first I'm going to go into the two programs that MODA currently has in place for PEBB. So first is Spring Health. And so Spring Health is really, I would say, a progressive behavioral health provider. They are set up as a client-specific network, so they're all in-network providers, and they do offer virtual and in-person counseling across Oregon. They have behavioral health coaching, therapy, and medication management services. They also have care navigators available by phone or email that help members find care, access care, they answer questions. And they all have their schedules online with their bios for quick and easy scheduling. They also use outcome-based measurements and have a really unique support structure for their affiliated counselors. And then Maru Health is also in place, which is a 12-week program for anxiety, stress, and depression. It has therapy, it has a peer community. And the interesting thing about Maru Health as well is they have a bio feedback device that is part of their program. And this really teaches members to improve their physical response to stress so that they can really feel calmer faster. It's a small device that clips to a person's earlobe while doing breathing practices. And then the programs that are being proposed again by MODA this year is BH360. This includes that BH Champions, which is that navigation support, finding providers that match members' needs with verified availability, and they also perform follow-up to make sure members' needs are met. And then also under this BH360 program that's proposed is Gemini, which is a discrete video modeling program, which means it's just a digital-based videos for children that are diagnosed with autism spectrum disorder and other developmental needs, such as Down syndrome. It does have coach support for parents and some additional resources. And then lastly, Hazelden Betty Ford. There's a little distinction here to make is that the Hazelden Betty Ford inpatient facilities are in network currently for PEBB. This program and what this is referring to is an online resource and education center that Hazelden Betty Ford has in place, as well as a case management kind of step down program for 11 months of somebody who's been inpatient with a Hazelden Betty Ford facility that would then step down to a different type of care, and they would have this 11-month case management program. So that was a lot, but I wanted to make sure I provided you all with a foundation of what all these programs are that we're looking at. Again, in March, we will be sharing with the CIAO group the assessments and findings thus far with some recommended actions to take. I think if we move to the next slide, this is just a kind of overview of the proposed program, again, for the Behavioral Health 360. This has been proposed previously by MODA as well, and I just want to make sure I'm clear about that, and tried to say the components that are already in place is the Spring Health and the Maru Health, and then the other components that would be included if the board decided to move forward with this. Any questions from the group on any of these programs? Or broader clinical topics that CIAO is looking at? All right. Well, thank you.
All right, thank you, Christy. Oh, Emily, you have your hand raised.
Yeah, thank you, Christy. That's a lot of information that you just
It is.
shared. You guys are so talented at synthesizing in an understandable way. I was just curious if, and I'm just trying to track and read at the same time, so I might have missed this, but have you all talked about like the members and their family members who identify as LGBTQIA2S+, and just like some of the stress and anxiety that they're feeling right now. And I think I had mentioned in a previous meeting just the dramatic increase of calls that crisis lines are getting from the youth who identify as LGBTQIA2S+.
Yeah, thanks, Emily, for that question. And Mercer in general is tracking, I think, the increase and just how everyone is feeling right now. Across our different organizations and trying to provide the support and guidance as best we can. I think, Canopy does have, again, this critical incidents response. And so what we have been seeing is that some organizations have been using their EAP critical incident hours as a way to have a more, a virtual event for people to join that is moderated by a licensed clinician and just, again, gives a safe space to, just be able to have that discussion. And again, it's kind of been on an individual organization by organization basis on whether they want to have an event like that. But we certainly can talk with, I know Teresa Cross, works closely with Humberto at Canopy on managing that relationship and what those education and kind of support components are. So we can take that back as and something to look at, and also ask Canopy if they've had an increase, I guess, in some phone calls or requests for support from agencies.
Yeah, that would be great. And I know we have some structures in place in both OHA, for example, OHA, ODHS, and SEIU in terms of like the employee resource group, the queer collective, for example, or at SEIU, we've got the Lavender Caucus. So it might be interesting to explore in partnership possibilities to support our members and their families. Thanks.
Yeah. Yeah, you're welcome.
Thank you, Christy. Is that all of your slides? I was looking around.
So I think that's it for the behavioral health. We've got a couple more on dental and vision and some of the ancillary services, which, Don, I think I can get through in 9 minutes, unless I just jinxed myself. Does that sound good?
And then I missed that we need to consider whether we're ready to vote on a canopy renewal. So we'll need to come back around to that.
So I think on the canopy, oh, sorry. So I think, Christy, we still had a couple of items that we were negotiating with Canopy. And so I think our recommendation would be to defer the vote until next month.
Correct.
Yep.
Thank you for that recommendation. Please go ahead, Andrew, with these slides.
Alrighty. Okay, so dental. Let's jump to the next slide, please. So here are the 3 dental carriers that PEBB is partnering with today. MODA on the left in green is self-insured. Both Kaiser and Willamette Dental Group are fully insured. Starting with the Delta Dental plan, from a gross cost perspective, costs are projected to increase 3.4%. The administrative component of that is a 1.9% increase. There are a couple of plan design changes that have been proposed, which are those 3 bullets in the left box. They all have a negligible cost impact. I'll go through them real quickly. The first is around sinus lifts and bone grafting. And so these are procedures to make sure that there's enough space in the mouth for dental implants. The next one is around non-IV sedation for members who have intellectual and developmental disabilities. And so this is, again, sedation without using an IV. You might recall this time last year, the board approved some other enhancements for members with intellectual and developmental disabilities. And so this would likely be a good enhancement along those lines. And then the third is around x-rays and the cadence for when those are covered. And so there was a member who brought forth an issue around a discrepancy between how the plan was operating versus the handbook. And so in working through that, we came to the conclusion that x-rays are covered 2 times per year today, which is richer than the ADA, the American Dental Association standard of care, which is 1 time per year. And so this is a change that would changed the frequency from 2 times per year for x-rays to 1 time per year. And you can see there's a very slight cost reduction associated with that plan design change. Kaiser has a couple of book of business changes that they're making across their dental book of business, which I'll get into in the next slide. So I'll pass over that. As Emery had noted, we don't have the proposed preliminary rates from Kaiser, but we will when we meet next month. And then Willamette's rates are proposed to increase 7.9%. So, the claims and utilization for that plan have been running a little bit higher. We do have some questions and some discussion we've had with Willamette around the trend factor that they're using for that projection. And so we'll continue to have those discussions. But I did also want to call out that some of the staffing issues in some of the clinics at Willamette have gotten some positive movement. And so in the Eugene and Springfield office, it is now fully staffed, and they have successfully worked through the sort of backlog of PEBB members who are on the wait list, which is great. And then the Albany and Corvallis Willamette office is also now fully staffed. They haven't worked through the backlog yet. They're actively doing that. But those are both very sort of promising developments with regards to access for those members enrolled in Willamette. And it's something that we've been tracking for quite a while now. And so glad to see that positive movement. Any questions before I move on to talk about the Kaiser Book of Business changes on the next slide? Okay, I think we can proceed. And so these are changes that Kaiser, again, is making across their dental book of business. And really the intent is to streamline some things from an administrative perspective. And so you can see these 3 changes around nitrous oxide member cost share for emergency dental services, and covered service around tooth-colored composite fillings. And so with the first one, nitrous oxide cost share, this changes the cost share from $0 to $25 for younger members, which is consistent with older members as well. And so it is a little bit simplified from an administrative perspective. I'll go through the other 2 as well, and then I'll pause for comments. Emergency dental services, this one changes member cost share when they have an emergency dental need and they're outside of the Kaiser service area, and so they have to go somewhere else. And so currently, for members in that situation, they'd be responsible for any charges over $100, which could be significant. And so this change would provide a little bit more financial protection for members in these scenarios, which doesn't happen often, as you can see, one impacted member over the last 12 months. But the change would change the cost share to regular member cost share and then any amount over usual and customary charges, and so essentially balance billing. However, that's more security than the current arrangement, which is any charges over $100 will hit the member directly. And then with the final change, this is around tooth-colored fillings, and so currently the tooth-colored fillings are only covered for those teeth that are within the smile line. And so teeth in the back would not be eligible to get the tooth-colored filling. And so this change would essentially change that and say, regardless of where the tooth is located in the mouth, it is eligible for tooth-colored composite filling. And so these collectively are pretty small from a cost perspective. You can see we've noted the impact on the top right, about $16,000 in annual cost increase taken all together.
I really appreciate the number of members impacted here as well, Andrew. Thank you.
Oh, good. Yeah. And I see we've got about 2 minutes here, so I will try to talk fast without talking too fast. And so next we have Vision. This is a self-insured plan with BSP. From a gross cost perspective, slight decrease, which is that top dark row, minus 0.3%. The administrative fees and rate guarantee, and so that is flat at $115 per employee per month. VSP did propose an enhancement on the base plan to cover retinal screenings at a $10 copay. With the richer plan, the plus plan, that's the design that's in place today. It's $10 copay for retinal screenings. Today on the base plan is $39. And so it is a covered service today on the base plan. This would just make it a more affordable for members. And so I guess stepping back, retinal screening is a procedure that sort of prevents the need to have your eyes dilated, and so it is pretty convenient for members. However, that said, this enhancement does come with a cost impact, noted at the bottom there, a little bit under $300,000, and so given PEB's financial position, maybe not the year to make that enhancement. But we can talk about that some more as we proceed. But if we want to jump ahead, I've got, I think, 2 more slides, and I've got 1 minute. So these are some of the supplemental program renewals. ASI Flex is your vendor partner that administers your spending accounts. And so healthcare FSA, dependent care FSA, and commuter account. There are no proposed changes in the fees for those. And then on the right, Benefit Help Solutions is your administrator for COBRA and self-pay premium administration. And similarly, no change in proposed fees for the upcoming plan year. Any questions on those two? Okay, all right, let's go to the next steps. Thank you, Rose. And so we will, in March, we will likely be asking board members, you to take some action and vote on some things. And so that would likely be Canopy, perhaps some of the non-medical programs to the extent you're feeling ready to vote on those. We'll continue in March to talk about PEB's financial position. We will likely come with more specific content on ways to reduce that $68 million. Of course, that number could change as Emory incorporates additional months of claims data. That could help, that could hurt as well. And so we'll know when we know. However, we will bring forward a menu of options, I guess I'll call it, around plan design changes, other ways to reduce cost, and start having that conversation. When we've looked at plan design changes in the past, there are certain types of changes that we want to prioritize, those that encourage long-term strategies instead of sort of knee-jerk one-off ways to reduce costs. Obviously, equity will be a big part of any potential change that we talk about. Another area is bringing benefits parity between the carriers. And so if there's one carrier that is much richer in some provision within the medical plan, there might be an opportunity to align that with the other carriers and thus reduce 2026 cost. And so more to come on that topic. When we get to April, we will hope to make final decisions for medical and pharmacy for the 2026 plan year with final approval of rates in May. Some years that happens a month later, and so that would look like May, June. And so we'll see when we get there if we need to have another month to discuss the plan options, or if not, or if you all will feel ready to make those decisions in April. Okay, apologize for talking quickly. Hope that didn't discourage any comments or questions. Happy to take any now if folks have any. We're still pretty much on time, so I think, Dawn, if you're okay, we could open it up for comments and questions.
Sure. Any comments or questions for Andrew and the team? Hearing none, that was a lot of information. Annalee, your hand.
Yeah, sorry, and I can follow up later if there's not time. But I was just curious with the ASI Flex program, if there's like an appealment process. I think there might be, right? Or so curious about that.
So, Emily, are you referring to an appeal if an expense is denied by ASI Flex?
Yeah, just like part of the ASI Flex covers parking reimbursement pre-tax. And so there have been a variety of parking issues, especially for downtown Portland members. And so, miss of different deadlines and things. And so just curious if there was an appealment pathway for that. Oh, and Ollie's. Probably an Ollie question.
Oh, yeah. Well, yeah, there we're kind of restricted in many ways by ASI Flex. It's kind of the one benefit that, it's governed by IRS regs, so very little flexibility and or interpretation when it comes to those FSAs. But we can follow up, Emily, on
Oh, great.
any specific type of appeals that you're thinking.
Oh, okay, great. Thanks. Thanks, Ollie.
You bet. You bet.
Thanks, Ali. Anybody else? Questions for Andrew and the team? I'm hearing none. Thank you. Let's go ahead and transition. Next on the agenda is the well-being survey results. Teresa Cross, Drs. Stephen Neldner, and Peter Rutigliano. Are you with us?
Thank you. And hello, everyone. Teresa Cross, PEBB Wellness Manager. I'm happy to be here with Dr. Stephen Neldner, and I think Dr. Peter Rutigliano is here with us too from Mercer. Today, we're going to cover some high-level results from the well-being survey that was conducted last spring. The results that you'll hear about are most relevant to the topics that the board would be interested in, which is benefits. So here is a list of the items that we're going to cover today. The survey, how it was conducted, who responded, benefit-related responses and questions and responses, how PEBB stacks up compared to benchmarks that Mercer collects from other industries, and we'll look at recommendations that came out of the survey. Next slide, please. So the survey covered 5 topics or 5 key areas of well-being, and those are listed there: social, emotional, physical, financial, and spiritual, intellectual well-being. The survey was conducted over a 7-week period last spring. It included 79 questions plus the 41 required Real D SOGI questions. This is the first time this particular survey has been conducted, so we see it as the baseline by which we will compare future survey results to. The other thing that we want you to know is that our survey results are being compared to other benchmark results, and we'll go have a slide that shows you what that looks like. And those benchmarks are global, USA, education, and public sector groups. Next slide, please. So as I said, the survey was conducted last spring from April through May 24th. This was an email invitation that went to all PEBB members that had email addresses. The communications team at PEBB also developed some promotional materials and posters where folks who may not use email or might not have easy access to email during the workday, their work shift, could use a QR code to access the survey. The response rate was 19%. So out of almost 60,000 surveys and people invited, 11,279 responded. And based on those respondents, we feel that that is representative of our population. We worked very hard to convey the need to protect people's confidentiality. And so all of the information that's got sent to members in their email invitation to participate explained how we did that. And we being PEBB did not see any of the information. It went to Mercer. Mercer analyzed the information. We also used a threshold of 200, which was information that we have used or threshold that we've used in past surveys around well-being, that if there were responses in a question fewer than 200, we will not share those results. And we also collected several comments because there were several qualitative questions where people could enter their responses, and no one in PEBB has seen those. Those were all collected by Mercer and then grouped into themes. Next slide, please. The demographics of who responded to the survey, a little more gender, age, race, ethnicity, and residential region were all looked at. Members over age 47 participated at a slightly higher rate than members under age 47, and more females participated than males, but not to any degree that we felt that the results were going to be any different from or non-representative of our membership as a whole. Next slide, please. So when Dr. Nelner dives into the results here in the next slide, you'll see that the bar charts are divided into 3 colors that tell you where we are. Are we doing well? It will be in green. If we are having maybe some opportunities for action where we can do better, you'll see those in yellow. And then if there are some significant opportunities discovered, those will be in red. And in fact, you will see that in these 3 areas of well-being, that's exactly what you will find. We are doing well in physical well-being. We could improve in our emotional well-being, and in financial well-being, there are some opportunities. Next slide, please. And I'm going to turn this over to Dr. Stephen Nelner, and he's going to dive into the specific results with you.
Thank you, Teresa, and hello, board members and others. So we are focusing primarily in this reporting today on benefits-related questions. As you know from the large number of questions, of 74 questions, many of those questions are related to the workplace and emotional state at the workplace, conditions at the workplace. But for the sake of the board and what you're responsible for most directly, benefits, we've decided to focus just on those questions that were directly related to benefits. So first of all, under the realm of physical well-being, you can see, let's just do a little lay of the land here. First of all, you can see that there are 2 lines that go across the bar graphs, one for manager responses in the navy blue, and the pink color for non-manager responses. And as Teresa already mentioned, we've got red, or whatever color they're close to red that is, indicates unfavorable responses. Green is favorable, and in the goldenrod, it's neutral response. So that'll be the convention that we use for all the bar graphs throughout these next few slides. So in the physical realm, for the most part, you're doing quite well. You can see that 75 to 81% of the population responded favorably to the benefits I get from my job, help me feel good and stay healthy. I have a healthcare provider who takes care of my health, and I trust them. I go to a healthcare provider regularly to make sure that I am healthy, and overall my health is good, favorable. The 2 areas of opportunity that are indicated in these questions are question 43 on the far left. I usually get enough sleep to feel rested and healthy, and only 52% of the people responded favorably or positively to that. 30% of the people said they probably aren't getting enough sleep, and as you can see, about 18% of the people were neither favorable or unfavorable there. On the far right, I have a health condition that needs medicine, checkups, or treatment on a regular basis. This question, as you can see, is answered in the negative. So a positive answer, an answer to yes to this question, would mean that the individual does indeed have a condition or needs checkups or regular treatment. So to normalize the colors on the bar graphs, we've used the reverse scale here. So what this means from the far right for question 61 is that 56% of the population says they actually do need medications, checkups, or regular treatments. Only 40% of the population does not. So there's an opportunity, and I think the reason that we highlight that under benefits is the fact that over half the population does need regular medical care and monitoring. So the benefits that you provide them around their health care is very important to them. And if there are any questions along the way, please have us pause. Otherwise, we'll keep moving to the next slide. Emotional well-being. So 2 questions that we picked out here, and you can see that they're both fair results here in the high 60% range, giving a favorable response to question 38. I know how to find and use PEBB benefits that help me take care of my mental health. And then the benefits my job gives me help me and my family take care of our mental health. So somewhat favorable there. I'll point out that there's a relatively large percentage of people who are neutral and or responded in the neutral zone. And that's hard to interpret. We don't have the specificity to know why they responded. One hypothesis could be that they didn't need to use their mental health benefits, so therefore they didn't have a positive or negative impression of them, or they could just feel ambivalent about them. They were okay, but not necessarily strongly positive or negative. So we really don't know what the neutral respondents mean. Probably more likely that they probably didn't even need to access the mental health benefits. But again, we don't know for sure. But I think the positive takeaway from this slide is that from how to find and use PEB benefits around mental health, only 15% said it wasn't favorable, so they probably couldn't find them. And only 7% to question 39, my benefits, that didn't think that their benefits helped themselves or their family with their mental health. So overall, pretty good results there. Next slide, please. Under financial well-being, and this was an area that was a little bit more mixed. You can see that we have some questions that were more unfavorable than favorable. That's number 68, question 68. I'm confident that I'm putting away enough money for when I retire. This was another one that's difficult to really interpret for your PEB population because we know that your members have benefits through the state retirement system. And from feedback that we received from those who are part of the conversation, not everyone really knows what those benefits are and what the magnitude is and what those will look like when you actually do retire. So there's probably some lack of understanding and knowledge about what portion of my retirement do I have to fund myself over and above what I'm going to get from my retirement from the state. On the far left, my benefits, the benefits my job gives me help me manage my money well. You can see a very large percentage of neutral. So again, it may be people that just really haven't looked to their benefits to help them manage their money. But 43% gave a favorable response and only 17% an unfavorable one there. I feel like I can manage my money well. Most people, 75%, feel that they're able to manage their money quite well, even without benefits that help manage them. So that's a positive sign. Moving on to 69, I sometimes don't get the health care I need because I don't have it. Again, this was a reverse question. So if you answered yes to that question, that was unfavorable. Most of the people aren't sacrificing getting health care. 72% are saying they're not sacrificing getting health care when they need it because of financial needs. And similarly, sometimes have to give things up that help me stay healthy because they don't have a lot of money. 22% said that's the case, that they probably did sometimes hesitate because they didn't have enough money, but 63% said that they didn't seem to delay care because of their financial situation. Pause there for any questions if you have them. And if not, we can move on to the next one. And I'm moving quickly too because of the time. Here's a slide where we've actually had some benchmarks that we could compare for some of the questions. And this is across several of those areas we've already discussed. Question 43, I usually get enough sleep to feel rested. We have a benchmark from NIH, and this is a government benchmark. It's a global benchmark. And you can see that 52% of the people getting adequate sleep is probably 14 percentage points below the global mean from that NIH benchmark. So an opportunity there for sure. Next one is the benefits I get from my job help me feel good and stay healthy. You can see that compared to the global mean, that's all of Mercer's book of business in the US and across the globe, you're 4 percentage points higher. Just for the US mean, 2 percentage points higher. Education slice, 4 percentage points higher, but compared to the public sector mean, slightly lower than benchmark. Then on the far right, question 68, I'm confident that I'm putting away enough money for when I retire. Again, you can, from what we said earlier, it's the maybe some confusion about what they'll need, but nonetheless, this reporting and these responses show that from the global US and educational mean, you're significantly below the benchmark for those different populations. So that appears to be an opportunity, and it may be just an educational opportunity. Hard to know for sure, but probably worth digging into more. And with that, I'm going to turn it over to Teresa, because she's going to share some observations and recommendations about how to deal with some of these responses. Teresa?
Thank you. Before we go to the next slide, Dr. Nelner, I just wanted to mention an addendum to this last point you made about question 68. I'm confident that I'm putting away enough money for when I retire. Even though PEB performed lower in that compared to these other benchmarks, isn't it true also that we discussed possibly this being a symptom of the larger, broader economic concerns that people may have been experiencing? Recall that the survey was conducted last spring, and the economy and people's perception of the economy and how well they were doing economically was an issue that we heard about.
You're right. Absolutely. Yeah. I think that is something we discussed, and is a possibility that could have influenced the responses at that time. And the economic situation, as we know today, is probably not that much different. So we may be projecting that ahead as well. But it is certainly, any survey is subject to the current situation at the time of people responding to a survey. So that could indeed have influenced the response to this particular question. Thank you, Teresa.
Thank you. Rose, could you please go to the next slide? I will try to be, I think this was one that you were going to cover also, Dr. Nelner.
Yes, I can cover this one as well. Yes. So these questions, you can see the title is, these are uniquely scaled questions. So this was a set of questions or question and responses that people could select as many as they wanted to for any of these. So the question was, which of these well-being programs help you feel good and be healthy? The very first response, the largest response of all, was, I'm not familiar with any of these programs. 42% of the people said that. That's probably a big opportunity, and we certainly are discussing that with staff and with your carriers and vendors about how to make the programs that you already are offering more available, more understandable, more easy to access. So that seems to be a takeaway from this. Then the next item as well, none of these programs help me feel good and be healthy. Close to 20% said that those programs that apparently that they've experienced weren't really helping them or making them feel good or be healthy. So probably another opportunity there as we look at the relative value of any and all of these programs going forward. From there, you can see the distribution of people that are actually using and find those to be useful in promoting their health and well-being. And I'll just note that because there could be more responses, they don't necessarily add up to everybody responding to this question, or individuals may have had multiple responses. John, I see you have your hand up.
Yeah, it might be useful at some future point, maybe offline or something, to have a parallel chart of what would in general the pool of opportunity be for each of the items. So for example, I think we have some general estimates of obesity in the PEBB population. So like that would be the potential pool of Weight Watchers. Like you don't really have a need for weight, like you're not going to use it if unless, like, I guess, if you're maintaining weight. Similarly, like I don't know about like complex health, multi number of people with multiple uh chronic diseases would perhaps be the pool for health coaching and so on. Like because I don't think we would expect any of these would be like 80% or whatever. So it would be nice to be able to see like a general idea of like what what's the target? Like some of these, it might be appropriate that it's 2% because it's like, yeah, it's about 2% of the population has that, whatever. So just something to get to help us sink our teeth into it, you know?
Yeah, that your point is well taken, Sean. And actually, the PMAC and the Worksite Wellness Coordinating Council are working on that right now on some of that. Some of the first programs, one of the first programs we're looking at right now is the diabetes prevention program. And we're looking at the actual participation rates in the various programs that are available relative to the percentage of the population that's likely eligible for those programs. And I can tell you, I'll just say anecdotally that quite low compared to the actual prevalence in the population of people who'd be eligible to use at least the diabetes prevention program. And similarly, staff and Mercer are taking a look at other reporting that we're getting from Weight Watchers, for example, and other of the point solution vendors. And we'll be compiling that information and certainly want to share that with the board. No other questions? Teresa, now I think so.
Go ahead, please.
So I have a leaf blower right outside my window that came a little early. So I'm hoping that that's not going to be bothersome to the people at on the other end here. Based on the results, Mercer had some observations and some recommendations. So the opportunity here is that 20% of the people who responded to the survey said that the benefits do not help them get healthy. 40% say they were not familiar with them. And that's the biggest opportunity in my mind, is that helping people know that their benefits, whether they want to use them or not, are there, and so that they are aware of them. In terms of physical well-being, we covered some of those strengths there. When Dr. Nelder went over the bar charts, the opportunities here is that members, only half of our members are reporting getting enough sleep. So another opportunity to be promoting some of our sleep, the carriers' sleep programs and sleep hygiene resources. Next slide, please. In terms of emotional well-being, 2/3 of our members know where to go to get mental health benefits. That's good. We want to continue promoting our benefits. We want folks to know that in addition to Canopy, the Employee Assistance Program, each of the carriers also have emotional well-being supports and resources. And the financial well-being, the opportunities here really are that financial benefits are only helping about 40% of our members. So we have some of the carriers and the EAP have financial benefits that are resources that are available to them. This is not a typical topic that you usually think of when you think about well-being, but financial well-being has a very big impact on how you feel physically, especially if you're not feeling comfortable that you're saving enough, that you have enough to get through the month, or that looking ahead to retirement, that's a concern. So we want people to feel comfortable and confident that what they have available to them is helpful. And I think if we go to the next few slides, these are the resource slides that we're not going to go into. Lots of information here. This is kind of the high points and the not so great points in each of those dimensions that I mentioned earlier that the survey was looking at in terms of well-being. So we invite the board to take a look at those, and please do direct any questions to me or to Dr. Neldner. We're happy to help you dive into these more. The larger agencies will be able to access their results, larger agencies meaning in terms of employees and how much participation they had in the survey, so that they can see how they stack up compared to the larger PEBB population as a whole. Thank you for your time.
Thank you, Teresa and Dr. Neldner. All right, let's go ahead and move through those and come on to the next section, please. I'm going to have to ask that you keep this presentation pretty tight, given the timing. Is that going to be, who's getting this one?
Hi,
That's
Don. That's Cheryl Stein from the Mercer team. Yeah, Cheryl, I'll hand it over to you.
Yeah, perfect. And I'll probably skip over some sections that I have been planning to cover to focus in on certain topics. So I will try to be as concise as I can. So if we go to the first slide, I'm actually going to skip over this one, in the interest of time, but just noting that this slide, along with some additional slides that we have included in an appendix, provides some kind of general thoughts on certain priorities that we might see coming out of the new administration with respect to healthcare policy. But I will plan to kind of focus on some of the executive orders that we've seen coming out recently and how they may or may not impact health plan administration. So if we move to the next slide. This first slide highlights several executive orders in kind of the healthcare realm that generally don't have any immediate impact on health plan policy. We've seen several executive orders, Biden era executive orders that have been rescinded, including some related to drug pricing and ACA marketplace enhancements. I do want to hone in a little bit on some of the executive orders and how they may impact future regulations that we see. First, we have a regulatory freeze order, which is very typical of new administrations to kind of give time for new leadership to be confirmed by Congress and to review any kind of proposed rules that are out there for alignment with priorities. So this won't have any impact on any final regulations that have been released and finalized, such as the mental health parity rules or the HIPAA reproductive privacy rule, but it does impact things like recently proposed cybersecurity rules, for example. Next, also related to regulations, is a 10-for-1 order. So if you recall, in his first term, Trump required agencies to eliminate 2 rules or guidance documents for every significant regulatory action that was added. This time around, we're looking at that 10 regulations must be identified for repeal for each new regulation. So that's a significant increase there. And also, the rules will require additional scrutiny beyond what we've typically seen. One thing to kind of keep to note is that the Administrative Procedure Act can, generally make eliminating rules a slow process by requiring the writing of new rules to replace old ones. So again, we're likely to see kind of some slowdown and, obviously some slowdown in terms of regulations moving into this new administration. The last one on this slide, we have an executive order related to gender identity, which instructs federal governments to recognize only 2 sexes, male or female, that they're not changeable. So again, we may see some impacts to certain how the government will continue or discontinue its enforcement of certain Biden era rules, including, for example, the ACA Section 1557 non-discrimination rules that currently define sex as including gender identity. So we'll have to keep an eye on that. But let's move to the next slide, which has maybe still not quite immediate impacts, but impacts on access potentially. So first, we have the Office of Personnel Management issued a memo on January 29th, giving federal agencies until 5 p.m. to end all agency programs that use taxpayer money to promote or reflect gender ideology. And so we saw some impacts there, but probably the one that we're all closely watching is the executive order regarding gender affirming care. So this order's stated goal is to ban federal funding or support for child gender affirming care, which includes both surgical procedures and hormone therapy, and redefines child to mean those under age 19 as opposed to 18. So again, it aims to condition federal research and education grants for healthcare facilities, so hospitals, medical schools, and provider participation in Medicare and Medicaid on the termination of gender affirming care for minors. Also directs the DOJ to prioritize enforcement in this area. So this order on its own doesn't make providing gender affirming care illegal, particularly in the states that don't have laws prohibiting this. But losing federal funding and grants and the risk of litigation is a serious threat to hospitals. Within days of the release of this executive order, there were press reports of several major hospitals pausing gender affirming care for minors, delaying procedures. For example, more locally, we have had Seattle Children's Hospital here in the Pacific Northwest. One area that PEBB will want to keep an eye on here would be impacts related to Oregon House Bill 2002 that not only, it kind of conflicts here, not only mandates that carriers in Oregon must cover medically necessary services for gender affirming treatment, but also includes a network adequacy component. So we'll want to watch that. It's at this time, it's possible that the federal agencies will issue new or amended regulations that could impact group health plan coverage for gender affirming care, but we're not quite there yet at this point. It is also important to note that there have been 2 lawsuits filed, one by Washington State, joined by Oregon and Minnesota, and also one by the national advocacy group PFLAG. And on Thursday of last week, a federal judge has temporarily halted enforcement of this executive order through a short-term temporary restraining order. So we'll continue to watch that. Also on this slide, we have some information on an executive order that bans the use of federal funds for elective abortions, mirroring what we often see is in the Hyde Amendment. So there may be some impacts related to reproductive health access as well. And I'm running out of time. I just really quickly on the last slide want to highlight a couple of executive orders that came out late last week. One is the establishing the Make America Healthy Again Commission, which is really focused on lowering chronic disease rates in childhood and childhood chronic disease. And we do see it's kind of speculative at this point what we might see kind of coming out of this. We could see the group kind of looking at anti-obesity drugs, vaccine recommendations. The vaccines were kind of notably left out of the language of this executive order, but we also could see perhaps some interest in pre-tax or HSA coverage for things like gym memberships or other programs like the Food for Medicine program that was mentioned earlier in the call today. So that, again, glossing over a lot of details to give you all a couple minutes to wrap up. But let me know if there are any questions on any specific areas.
Dawn, if I may, I just want to make a brief comment after hearing all of this very sobering information coming out of our federal government. And I just really appreciate that as the PEBB board, we have had many retreats and agreed on principles organizationally that lead us on a path that we want to provide equitable care to our members and for that care to be affordable. And we care about the member experience as well. And certainly I've heard from PEBB members about concerns about what's happening at the federal level. So just appreciate you bringing that to the board.
Absolutely.
Thank you, Cheryl and team. There are no doubt many questions associated with this, and it's still, of course, early days. Some of this is already concrete. much more of it is not yet concrete and much to come. Thank you for keeping your eyes on it and your finger on the pulse and bringing us insights as to ways that we may be put in a position that we have to address things directly, such as potential conflicting mandates at the federal and state level and that kind of thing. So thank you.
Absolutely. And we'll continue to bring those as more concrete items or kind of arise out of this.
Thank you. Now I would like to turn to public comment. And if I may, we do have some written public comments that were sent to the board by email. We also have one oral public comment today requested by Richard Botterill, who I saw in attendance. If you are here, you will have 5 minutes for your oral public comment today. I would ask board members to please reserve comments until we have time to consider a future agenda item that might include time for open discussion. And lastly, while we appreciate and acknowledge the public comments issued today, PEBB directly contracts with Providence Health Plan, which is a separate business entity from Providence Health Systems, although they have a relationship as well. So with that, Mr. Botterill, I would invite you to introduce yourself. The floor is yours.
Thank you very much, and good afternoon, everyone. My name is Richard Botterill. I'm a proud member of the Oregon Nurses Association, a member of the Board of Directors, and an emergency room nurse at Providence Portland, where I'm also the chair of the bargaining team. And thank you for giving us the time today to talk. I know it was a last-minute thing, and I really, really appreciate it. So I'm here to talk to the board to reconsider its relationship with Providence Health and Services due to their failure to uphold the integrity, the accountability, and patient-centered care. The primary concerns we have are that Providence has repeatedly ignored safe staffing standards, engaged in unlawful labor practices, and cut essential benefits like sick leave, like health insurance for their own employees. Meanwhile, they've increased their CEO's salary to over $14 million while failing to invest in frontline care. These actions, I think, directly harm both caregivers and the public employees who rely on Providence for their health care. And why this matters, again, from my perspective, and I know you guys probably have a much better idea of this than I do, is that this PEBB is required to go to responsible providers with a record of integrity. I'm questioning whether Providence's actions raise serious doubts about whether they meet that standard. And in closing, I would say that, again, you know better than I that PEBB must ensure public employees have access to ethical, stable, high-quality health care. And we urge you to hold Providence accountable and to explore better alternatives. And with that, I'll be quiet and say thank you very much for your time today. I really appreciate it.
Thank you. Please be advised, board members, that you do have 2 public comment attachments to your board packet, and I will take any final comments or observations from members of the board. Thank you, Mr. Botterill.
Thanks, Dawn. So I just wanted to say I really appreciate you bringing the concerns up, Richard, and I know that we have other public comment on this matter, both from SEIU and from AFSCME, as well as from ONA. And it is something that, just going back to the principles that we hold as a PEBB board, certainly we look at what the quality of care is at all of the carriers that we have, and we evaluate that through the RFP process, and also just concerns around how the workforce is treated has been part of that process too. So just want to make that comment as we go through the RFP process and as we go through renewals as a board.
Thank you, Siobhan. Any other members of the board? Ali, anything more at this time?
Rose, is there any additional public comments that came in during the meeting?
No.
No, we're good.
So
Okay.
thank you so much, guys. I'm going to drop off because I'm in the middle of a day of contract negotiation today. So thank you again. Thank you, Siobhan, and thank you everyone for giving us the time. I truly appreciate it. Have a great day.
Thank you. And I see in the chat that someone has noted that they have emailed another public comment. We will look for that. And in the meantime, I appreciate very much everyone's participation in today's meeting and thoughtful considerations of the issues at hand. Appreciate partnership. This meeting is adjourned. Have a great day, everybody.
Thank you.
Thank you.
Thank you.